Hyderabad, we have Dr. Kamal. She will be presenting this case. Dr. Riaz has joined. Dr. Kamal, Dr. Riaz is in the meeting also.
I don't see him, but Dr. Kamal can
Sir
continue.
is currently not here.
Okay.
Do you want to wait for him or we can continue?
No. Go
No
ahead.
problem. You go ahead. You go ahead because
Okay.
he asked me to yes add this case for the tumor. So I'm going. Yes, you can start. Please.
You can message him,
Assalamualaikum.
Dr. Hasan, please. Thank you.
So is my voice clear to everyone?
Ji.
Okay, thank you. Assalamu alaikum. I am Dr. Kamal Kamrani, a fourth-year resident at Department of Neurosurgery, LUMS, Hyderabad and Jamshoro. So our today's case is of a young lady. This was a 22-year-old woman who presented to us with complaint of headache for.
आप म्यूट हो गई हैं डॉक्टर कमल.
Initially, the headache that was relieved with oral painkillers and other symptomatic measures, but currently the headache is not relieved as such. She was also complaining of left-sided weakness that had lasted for the last 12 years. So the patient is currently mobile, completely mobile, walks without support and performs the daily activities. On past history, she has had a similar episode of left-sided weakness in 2012, which was initially improved. The attendant was giving the history that when patient had the first episode of left-sided weakness, she was completely bedridden at that time. It slightly improved in the next 2 to 3 months. Then later in 2013, she developed another episode of left-sided weakness, which didn't improve completely. Patient still has some residual weakness, but is mobile and is able to walk without support. Can I have the next slide, please? Okay, so on examination, this was a fully conscious oriented patient, 15 of 15 GCS. On a visual examination, there was left-sided homonymous hemianopia and also left-sided spastic hemiparesis. Power was of grade 4 plus by 5. Patient had bilateral papilledema, grade 2, and the left plantar was upgoing. So the Karnofsky performance scale was 80. I'm starting the images. So this is the CT brain plane, and we can see a solid cystic lesion in the right subcortical region involving the right-sided thalamus, the right basal ganglia, and also showing some perilesional edema. Can I have the next slide? So these are the MRI images, axial sections, T1 weighted, and we can see a well circumscribed lesion again in the same vicinity, which is extensively involving the right thalamus, compressing the ipsilateral lateral ventricle, and the lesion, as we can see, has some hyperintense signals as well. Some isointense, hyperintense signals, mixed intensity lesion, solid cystic inconsistency, also compressing the right-sided midbrain. Can I have the next slide, please?
जी, Dr. Kam. Can you see the next?
Yeah, sure. So these are the T2 weighted images showing some perilesional edema, a hyperintense lesion, again in the same vicinity. Can I have the contrast enhanced sections, please? And then we can follow up with the radiologist for the comments. Okay, so as we can see, this is a well circumscribed solid cystic lesion, heterogeneously enhancing and extending up to the anterior temporal tip, also involving the right-sided parahippocampal gyrus. And we can see there is some uncal involvement as well. I'm not sure if it is compressing the brainstem or if it is invading the brainstem, because in one section I can see that there is some invasion of the right-sided cerebral peduncle and the midbrain, and in another section I could see that there is some compression. So I would be very glad if a neuroradiologist can comment on these scans.
Okay, Dr. Shumaila, please. First. Okay.
Yes, thank you so much. Most of the findings are already explained by Dr. Kamal regarding the signals and location. To me, it seems, especially if we look at the coronal post-contrast images, it seems that it is causing significant compression on the brainstem with some descending tentorial herniation, because there is effacement of the basal cisterns as well. So doesn't seem like some invasion in this region, at least at macroscopic level. It seems that it is causing significant compression. It appears to be a high-grade neoplastic lesion, which has cystic and solid component. It has probably some hemorrhagic component as well, which is hyperintense on plain T1 weighted images. And it appears that it has multiple satellite adjacent lesions which are showing enhancement. If you look at the inferior aspect of lesion, there are 2 to 3 rounded nodular kind of things which are seen separate from the parent lesion. So this is a lesion which is causing significant subfill sign as well as descending tentorial herniation. Anything you want me to add?
Okay. No. So I can ask Dr. Shayan also. Dr. Shayan.
Dear Assalamualaikum. Thank you, sir.
Ji Wan.
Well, to me, this appears to be a solid concystic lesion which has a very minimal surrounding vasogenic edema, and it is confined to the basal ganglia and the temporal lobe. And if you look at the axial images post contrast, so we see this enhancement is very much close to dura, but we don't have those sequences or volume images to confirm whether it is attached to the dura or not. So, considering it also has intrinsic hyperintensity, which is indicative of a hemorrhage or an internal proteinaceous material. So, to me, considering its MR features, it looks more like a low-grade tumor, like a pilocytic astrocytoma or PXA, pilocytic xanthoastrocytoma, rather than a high-grade tumor. But of course, histopathology will decide.
Okay.
Over to you.
So
Ahsan,
I also
T2?
agree. I also agree that this looks like a parasitic to me, and both components of invasion and compression are there on the midbrain. You know. Okay.
Dr. Ahsan, can we see the T2 just once, briefly?
Yeah.
Can you see, Sarmal?
It doesn't look, yeah, it doesn't look to be invading, possibly. Okay, thank you, Ahsan.
I mean, invading किस लिहाज से?
So,
It is.
hyper.
Can
Well,
we
it's
have the
inside,
section,
yes.
please?
Yeah, it is
But what I
inside.
mean is this peel parasitization, hyperintensity in the surrounding normal brain structures.
You're talking about micro invasion की बात कर रहे हैं अगर आप ना, so it is invading in the brain parenchyma. There's no question, right? But there's not much edema around. And
Yes, the edema.
very sharp margins. So that's what I think the neurologists are talking about as well. ठीक है, आगे चलिए फिर.
So, Dr. Kamal, so yes, continue, please.
So this patient underwent a biopsy, just a biopsy with the right temporal craniotomy, and the patient is completely all right currently, mobile with no neurological deficit. The weakness is just as it was preoperatively, and we are still waiting for a biopsy. Can I have the next slide with the post-op scan? So this is the post-op scan after the biopsy. We are still waiting for the biopsy. We sent it to Aga Khan, and it has been, I think, 3 or 4 days, so we still have some time to
Okay.
go.
Dr. Kamal, do you have the frozen section? Do you do
No,
that?
we don't have the frozen sections. I think we discussed that in the last presentation. We don't have the frozen section as of yet.
Okay, so now the question that I'm going to ask to the, I think, oncologist is that, sir, so there is a possibility it might be the low grade pilocytic or it's a high grade. But if I ask you if it's a pilocytic, what will be your recommendation in this case? Dr. Mazhar, can I ask you?
Yeah, I think it's important that we should have a pathology. And since the tumor is, there is no edema and it doesn't look, it is sort of aggressive in a sense that it is compressing the brain stem. So I would prefer to, like if surgery, only biopsy is done and the residual tumor is lying there. Once the pathology come, I think then we can definitely sort of add adjuvant treatment to it. But I personally would prefer, if the patient is fit and young, I would give adjuvant radiation to the patient, but again, it depends on the final pathology.
Right. So Dr. Raza, if I would like to ask, what are your thoughts? So in this tumor, would you only do the biopsy? You'll go for more than biopsy?
I likely would go for more than biopsy. You know, in a situation as was pointed out earlier on, and there isn't a lot of, there really isn't any edema in the adjacent brain. It's got well circumscribed borders. So there should ideally be a decent plane with regards to resection. So ideally, more than a biopsy would be done for something like this. But, you know, now that the biopsy has been done, I think, you know, you guide the rest of the treatment based on pathology.
Right. Dr. Athar, would you like to add something?
Yeah, I mean, you know, so if the facility of frozen is not present, then I mean, we have to realize that it may be intimidating a little bit to go more than biopsy. लेकिन अगर frozen available है, so that would help. That will give the surgeon a little more courage to go ahead and do the resection. So I mean, I agree with Sean absolutely on that one. But at the same time, I just want to bring the point that depending on what facilities are available around you, we have to customize our response.
Okay.
I think my one suggestion would be should we bring the cases when the pathology is ready as well, because then you can more
Yes.
Yeah, I agree.
give.
Yes, sir.
Yeah.
Yes, sir. We try that, but you know, sometimes we have some limitations. So you know, when we get a request, then we see if we can accommodate the case. But you are right. So
Okay. Yep, absolutely.
Thank you.
so I think we have Dr. Asim also here. If I can ask him, Dr. Asim, sorry, I just saw you in the meeting. That if like we all know about the role of radiation in high-grade tumors, do you have anything to add for if the patient has a low-grade, grade 1 or something like that?
As far as radiation is concerned for low-grade myeloma, particularly when you're talking about the biological and though there is a literature available for radiation therapy in particular cases, but as mentioned by our colleague as well, that surgery is a main modality to proceed with. Radiation can only be considered in a situation where the surgical resection is not possible, or in case if there is a tumor shows some aggressiveness. Otherwise, the main modality for low grade, because the important issue is that when you can give radiation therapy in this situation, but because of the low MIP index and all these propagative index, the response to the radiation therapy is not as you can expect in the other tumor. So that's why. So if your question is regarding the role of radiation therapy low grade, when you're talking about the low grade, I mean the grade 1 parasitic asthma, because radiation therapy is also considered in the low grade like grade 2 as well. So there is a lot of data on the grade 2. But for parasitic asthma, you can actually find
what approach would we use? That would be something we can discuss, and that would help us as well.
Yes.
So, do you want to have a quick discussion on that, Asan?
Yes, sir. Yes, sir. Because we have time. Because I don't want to go for the third case today, because that will be very limited time, like 5 minutes. So we can talk about the approach now, the surgical approach. So, Dr. I see only Dr. Raza and Dr. Inam, so I can ask Dr. Raza the approach.
There's Dr. Noor also, and then there's Dr. Sarmad, and there's Dr. Altaf. There are a lot of doctors, neurosurgeon doctors. Yeah.
Okay, so I can start with.
So the problem is, if Shan says something, then everybody's going to just follow that line, right? So
okay,
maybe
we can ask Dr. Shan at the end. So,
no.
Yeah.
No,
Dr. Noor, what will be your approach?
Is the patient right-handed or left-handed?
Dr.
The
Kamal?
patient is right-handed. The
Right
patient
hand.
is right. Yes.
And can I have a sagittal images,
Do we have
please?
sagittal? Yeah, so we have.
Yeah, it's very posterior.
कोरोनल भी देख लें, कोरोनल भी अगर देखते हैं हम लोग.
Yeah. I mean, I would do a temporal, right-sided temporal approach, and I would go through a middle temporal gyrus. And since it's a right side, and I think I would get a very good plane around the lesion, because it's all like cystic everywhere. Like I think I would do a right temporal crani, take a middle temporal gyrus, and do a trans. I mean, I would do a cortical approach, transcortical approach.
What about awake versus non-awake in this case? Since you're
I
to the next.
That's the reason I asked that whether this patient is right-handed, and also like I mean I don't think that awake would benefit in this case, and it's and also it's involving the amygdala and hippocampus too. So I don't know that I don't think it's awake would be a benefit in this case, but
Will you go for? Will you do the tractography, Priya?
yeah, that might help. Yeah.
Okay, Dr. Noor, thank you. So I can. Dr. Altaf is also here. I can see. Yes. Dr. Altaf.
I simply say I agree with Noor.
Okay. Dr. Sarmad.
So, looking at this coronal section that you just pulled up, I might be wrong, but I'm actually thinking Transylvian.
Transylvian.
Because if you open the fissure, it's right there at the surface. That's that the cystic part, right? And you might not have to sacrifice cortex, and you could just like get right into it. Dr. Athar?
Yeah, I think that's a good approach to Transylvian. Yes. But I'm always afraid of the vessels, because when
Me
you're
too.
working
Yes,
deep,
sir.
retracting on those, even if you're not retracting, if you're doing dynamic retraction, you may hurt those vessels. यहाँ से फिर all of them are going to the parietal region from here, the blood vessels. Okay,
I mean, it's a right side, and it's a right temporal. You can technically do a temporal lobectomy in this side. So I think
you could also do that.
Yeah, middle
just get it
temporal
out of the way completely.
Yeah.
All right, the master comes in now. Shan.
Yeah, Dr. Shan, Dr. Raza.
I mean, I don't think I have anything intelligent to add beyond that. I mean, it's right-sided, and she already has a field cut too. So going transtemporal really has very little risk to it. And as much as I'm a skull-based surgeon, I love working around vessels. My feeling is, there's no reason to put the vessels at risk if you don't have to, right? So I think going transcortical makes sense for this case.
Sean, so a couple of other things. So I don't know, do we have CUSA in most of the centers? Dr. Kamal, do we have CUSA in LUMS?
Yes, we have. Yes, we have CUSA.
We have CUSA. Okay. So what are your thoughts about taking CUSA all the way down to the brain stem? Sean, what are your thoughts on that one?
CUSA near the brainstem?
Yes. And awake also. So what are your thoughts on the awake and CUSA? Yeah.
Sorry, in terms of awake. So in terms of the CUSA near the brainstem, I mean, I think it just really depends on your comfort level, right? And you can always dial up and dial down the setting, or a nice substitute for that also is a 12 sucker. I've seen that a lot. Done that a lot too for brainstem tumors too. So I think that's always a nice way to help find that plane when you're dealing with a tumor like this. Awake, I probably wouldn't do it, but I definitely would do tractography and the other considerations, whether or not sort of motor monitoring is needed for a case like this. But non-dominant, I wouldn't do awake.
Okay.
Would anybody in the group consider doing this awake?
Yeah, I mean, so it's so deep, but then I would consider doing it awake because I'm going right next to the corticospinal fibers, the pyramidal tract. So I can do subcortical क्या कहते हैं उसको ऐसे?
Motor mapping.
Yeah, subcortical mapping. Yeah, so that would help me. Although we have.
It's interesting. I think within our group here, there are probably two schools of thoughts. I think everybody would do subcortical mapping.
Right.
But there'd be, I think, a group that would definitely advocate for doing this awake for that reason, and others that would still do it asleep, but still do subcortical mapping. So we have that debate all the time. I don't know what the right answer is.
Okay. And then when you do subcortical mapping as under GA, you use a low MAC and you are looking at the EMGs?
Exactly.
Okay, all right. That's a good idea. Asan, we should think about that as well. And I don't know if other centers like LUMS and in Shaukat Khanum, they would be able to do that without awake. Sarmad left, right? But that's something that you don't have to have the awake team. You can do under GA. Just control the MAC and do the subcortical mapping with EMG.
I think we should try that, right? Yeah.
Right. There's I saw Dr. Saad Akhtar also, but he's not here
Yeah, I
anymore.
saw, but I was looking. I think he left, but
okay.
Yeah.
Okay,
so
wonderful.
the stage is open for the forum is open for the audience. If you want to ask any questions, you can unmute yourself or ask in the chat box. So one says, thank you all seniors for this wonderful tumor board, great learning experience. And then we got, okay, Sarmat left.
Okay. Right, great. Thank you very much.
Okay, so no more questions, and that concludes today's tumor board. Thank you so much. Thank you all.
And we will see you again in 1 month. Is that what you're
Yes,
planning?
sir. So we are planning now the tumor board the second Friday every month. So that's what we are planning. Let's see. So this was our third tumor board.